Morning, everyone. Today I will be presenting a case of EGM conference. Let me begin my presentation. This is a 34-year-old male. He presents with the complaints of palpitation, which the patient reports having experienced it past few years. And each episode lasts approximately 10 minutes, and this episode occurs about 3 times per month and characterized by sudden onset and sudden offset. And he has no past medical history. This is documented ECG, regular, narrow complex tachycardia. Heart rate was 150 to 160 milliseconds. And retrograde P wave visible in inferior leads. And this is normal sinus rhythm 12 lead ECG. And chest X-ray shows no cardiomegaly. And transthoracic echocardiography was revealed normal-sided cardiac chambers with normal global LV systolic function. Ejection fraction was 63% and normal LV filling pattern. Now I would like to present electrophysiological study. This is initial catheter position. 2 quadripolar catheter was placed in area apex and his area respectively, and duodecapolar catheter was placed in area and coronary sinus. And baseline normal sinus rhythm cycle length was 965 milliseconds. And during the RVP 600 milliseconds, the earliest atrial activation was recorded at coronary sinus 1 and 2. There is eccentric pattern. VA block cycle length was noted during RVP 260 milliseconds. And there was no VA decremental property during single ventricular extra stimulus. And tachycardia was induced by single ventricular extra stimulus 600 and 300 milliseconds. And narrow QRS tachycardia cycle length was 359 milliseconds, AH 150 milliseconds, HV 46 milliseconds, and QRS duration was 89 milliseconds. There is a same morphology of documented ECG, and narrow QRS tachycardia was induced by single ventricular extra stimulus. Ventricular extra stimuli at RV apex pacing exhibited V reset positive, and tachycardia was terminated with A, and AV block cycle length was during RAP 320 milliseconds. And AV node ERP was noted during single atrial extra stimulus 600 and 270 milliseconds. And tachycardia was also induced by single atrial extra stimulus 600, 330, and 600, 280 milliseconds. In summary, the earliest A during RVP was recorded at coronary sinus 1 and 2 eccentric pattern, and there was no VA decremental property during single ventricular extra stimulus. And in terms of narrow QRS tachycardia induced by single ventricular and single atrial extra stimulus, the earliest A was recorded at coronary sinus 1 and 2, and V reset positive with impression of orthodromic AVRT left lateral accessory pathway. This is ablation catheter position and pre-ablation signal during sinus rhythm and pre-ablation signal during right ventricular pacing 600 milliseconds. And during RF1, retrograde VA conduction via left lateral accessory pathway was blocked within 4 seconds during RVP 600 milliseconds. And booster ablation was performed. And after the ablation, during LV pacing 600 milliseconds, VA dissociation was observed. And also VA decremental property was observed during single ventricular extra stimulus. And during the single atrial extra stimulus, there was tachycardia was no induced. And this is EGM of normal sinus rhythm after radiofrequency ablation. And after the ablation, this is 12 lead ECG, normal sinus rhythm. Thank you for your attention.
Good job. Can you go back to post-ablation single ventricle study? Single ventricle.
After the ablation,
Stop. Is it VA dissociation?
Atrial sequence change. Cause of first year with the second difference.
Second and third and fourth atrial sequence looks different, right? Okay. Is it VA dissociation? Number 2 and number 3 atrial activation is retrograde conduction.
Yes, if you look at the CS910, the polarity is different. You can shift different. So second and third atrial activation is VA conduction. Right?
Go back. Go back. Yes. What is that? Very interesting. 라빙 직전에 모션스러움이 있었나?
뭐가 되는 순간인가?
먹이가 굉장히 번호가 굉장히 많네. Very interesting finding.
Then you capture the immediate before block.
엄청 타임. 이거 좀 찾아봐. 그 앞뒤로 어떻게 돼 있는지. 그다음 밑이 어떻게 돌아가는지.
Did you present the VA interval at the ablation site during tachycardia? Did you check VA interval
VA interval.
or CS1 to VA during tachycardia? Did you present? So when you present bypass trap, VA interval at the ablation site is very important. Because it should be less than 90 or around 17. So atrial tachycardia on the origin site and the surface A interval is important. Ventricular tachycardia, the site origin is the surface B is important. Also the AV anarchy, you should present the
I see the measurement. The interval measurements. During tachycardia and the sinus, we show the two measurements. So where's the HV interval measured? Sinus rhythm. Which one is HV interval? Don't see that.
Precision is not good. You should use the good is.
So when you measure the HV interval, AV interval, whatever, the target site is beginning of QRS. Okay, at the local electron. Please make sure. Nice presentation.
Nice.
그렇죠. 뭐?
And usually, so you email